On behalf of my colleagues in the organizing committee of the Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, all GCC countries, and all countries of the world, especially India. This webinar is CME accredited and is conducted in collaboration with NMC Specialty Hospital Dubai. I would like to thank the management, and it is sponsored by Vito Biotics UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali. Well, today we have eminent speaker, Dr. Vikas Dua, consultant pediatric hemato-oncologist from Fortis Memorial Institute in Haryana, India. In short while, I'll be introducing him. Well, as you know, today's topic is a journey of pediatric hematology from anemia to bone marrow transplantation. Please be with us. Beautiful Dubai, one of the most beautiful cities in the world. You see here Sheikh Zayed Road in day and night time. Dubai, a city which wants to be number one in all aspects of the life. Is already number one in tallest building, malls, all of you know. I would like to welcome those who have not seen to come to Dubai and visit. Well, there is a question. This time, really, those who answer, they will get a prize. These three scientists, if you can name them and tell their contribution to the field of pediatric hemato-oncology, and especially this gentleman in the middle. So you have about 2 to 3 minutes. Send your answer to the chat box or Q&A box. Dr. Tawfiq will consider, we will announce the name, and we will give a token of appreciation. Well, as we said, today's topic is the journey of pediatric hematology from anemia to bone marrow transplantation. Our speaker is Dr. Vikas Dua, consultant pediatric hemato-oncologist at Fortis Memorial Research Institute, Haryana, India. Of course, I will introduce him in detail. We have sent his profile to all the groups, and I'm sure you know about that. We have the moderators tonight, Dr. Kalpana Sengupta, senior consultant pediatrician, head of Department of Pediatrics at NMC Specialty Hospital, Dubai. She is joining us from Sky. See, the Dubai Pediatric Club is so famous that on the skies also people are following us. We have also with us Dr. Diari Muhammad, senior consultant pediatric surgeon at Agile Children's Hospital and chairman of the academic affairs. All of you know, and Dr. Dua here. Dr. Joshi also, he is traveling. He might join us as well, the past president of the club. Well, members of Dubai Pediatric Club in different meetings, on behalf of all of them and on behalf of the organizing committee, I would like once again to welcome all of you. Members of the organizing committee, Dr. Joshi, past president, Dr. Kalpana Sengupta, secretary of the club, Dr. Diari, chairman of the academic affairs, Dr. Muhammad Amir Toleimat, senior specialist pediatrician, Emirates Hospital, Dr. Ayman Jundi, consultant pediatric surgeon at Valiant Clinic and King's College Hospital, Dr. Rafia Ora, specialist pediatrician at Prime Medical Center, manager of this branch, Dr. Srinivas Bandari, who is in India, he is our honorary member, Dr. Leila Bahri, a specialist pediatrician at Green Life Clinic, and our encyclopedia of the pediatric, Dr. Khaled Rashid, who is also a senior pediatrician at different hospitals. Well, I would like to inform all viewers that on 17th of September, we are having a symposium on Sunday, 23rd. It contains pediatric surgery, gastroenterology, pulmonology, neonatology, infectious diseases, and vaccines. We will send you, the details. It is physical in Conrad Hotel, Dubai, where our 10th annual Dubai Pediatric Club conference will be on 27 and 28 April 2024 at Conrad Hotel. 2 days physical. We will have another online webinar separately. Well, here you see Dr. Tawfiq in 3rd Annual Dubai Pediatric Club. You see here Dr. Letkui, the founder of Dubai Pediatric Club. Dr. Ajit Kumar here, our chief guest, is felicitating him, and you see here Dr. Joshi, Dr. Kalpana as well. Well, I'll give a very brief account of the history of pediatric hematology. Some of these slides I have already shared with some of my colleagues. Those who have not seen, it will be just, I mean, some points will be interesting for them. Well, Dr. Louis Diamond, he is the father of pediatric hematology. Please remember him. And this is Dr. Oday Shuskar. She is the pioneer in pediatric oncology. Well, here it is interesting to know this gentleman here is Dr. Kenneth Blackfan. He was the head of the Department of Pediatrics at Boston Children's Hospital, Harriet Lane, Johns Hopkins. He came after John Holland, one of the fathers of pediatrics in America. When he was head of the department, students were attending his classes. One of the students was Dr. Diamond. When Dr. Blackman talked about the examination of infants, he became so interested in pediatrics, and after finishing, he approached to become resident. But many times he was refused by Dr. Blackman. He went and met all these doctors, friends. At last, he could convince Dr. Blackman, he became resident. He tried so hard. Then he published the first book, Atlas of Blood Disorder in Children with Dr. Blackman, which was published in 1948. Now, Dr. Diamond set the first pediatric hematology research center in the United States. In 1932, along with same Dr. Blackman, they identified erythroblastosis fetalis, later known as hemolytic disease of newborn. This I have mentioned. All neonatologists to know, he was the first to do exchange transfusion in newborn due to the, and this, he also introduced one of these Rh factors. And Dr. Blackman, those who have been to the Boston Children's Hospital, in front of that hospital, there is a circle. It is known as Blackman Circle. So he is the pioneer in pediatric neurosurgery. All those neurosurgeons should know. He actually described the hydrocephalus, internal hydrocephalus, and with Dandy Walker, he described many things. Well, here you are seeing two gentlemen. Here you see on the left side, this gentleman is Edward Glansman. We are talking about Glansman Thrombasthenia. He is the one, they are both pediatrician. And this gentleman here, Guido Fanconi, Fanconi anemia, Fanconi syndrome, so many. He was 45 years head of the Department of Pediatrics in Swiss. Also, Dr. Glansman, they are the two most important pediatricians, and they have done a lot of work in hematology. Well, now we will stop receiving the answers. This gentleman you see here is Dr. Thomas, Edward Donald Thomas. He is known as the father of bone marrow transplantation. Since today, Dr. Vikas is going to talk about bone marrow transplantation. Dr. Thomas, he died recently in 2012 at the age of 92. So remember Dr. Thomas as pioneer in bone marrow transplantation. A stem cell transplantation was pioneered using bone marrow-derived stem cells by a team at Fred Hutchinson Cancer Institute Center from 1950s to 1970, led by Dr. Edward Thomas, whose work was later recognized with the Nobel Prize in Physiology and Medicine in 1990. So he got Nobel Prize, remember him. Well, nowadays the name has been changed. Recently, the term hematopoietic stem cell transplantation has become the preferable term instead of bone marrow transplantation, with introduction of other stem cell sources, including peripheral blood and cord blood that Dr. Duavid mentioned. I'm not going to the detail of that. Well, briefly, I want to tell about the history of this. As I mentioned here, in 1955, Dr. Thomas began researching the possibility of using bone marrow transplantation to cure humans with life-threatening disease. The first successful bone marrow transplant took place in 1960 using bone marrow from identical twins. But the first successful transplant using marrow from sibling was not identical in 1968. And the first successful transplant using bone marrow from unrelated donor was done in London, UK in 1973. And of course, research began with patients' own stem cells in 80s, early 80s, and in 1988, cord blood transfusion was there just briefly. And those pioneers, Dr. Good in 1968, Dr. Kersey in 1975, I'm just mentioning Dr. Donald and his student, Dr. Gilbert. They are the pioneer in this field. Now, briefly about pediatric hemato-oncology in India, since our speaker is from India. Well, here I want to remember Dr. Bharat Agarwal. He wrote an article. Dr. S.M. Merchant instituted the first specialized center in India for diagnosis of thalassemia in children in Bijawadi Hospital, fortunately in Bombay. So in hemato-oncology, Bombay is on the front line. All from Bombay. Dr. Zeenat Kaur, those who have studied and worked in Bombay, they know her. Almost, I think all pediatricians in India, they know her. Established the first department of pediatric hemato-oncology in Bijawadi in 1984. Dr. M.R. Lokeshwar, considered the father of pediatric hemato-oncology, set up at same time at Sion Hospital, and Dr. S.H. Advani established a separate pediatric oncology unit at Tata Memorial Hospital in Bombay 80s. Those who have been there, they know. Well, here you are seeing Dr. Zeenat, Dr. Advani, and Dr. Lokeshwar. This is Dr. Lokeshwar, the father of pediatric hemato-oncologists, who wrote a book. In that book, Dr. Bharat Agarwal and Dr. Nitin Shah, they have written chapter. Both Dr. Bharat Agarwal, Dr. Nitin Shah, they are our speakers and members of the Pediatric Club. We are proud of that. And here you see the late Dr. Marwa. He has also written chapter. Who is Dr. Marwa? I will tell about him. Pediatric hemato-oncology as a separate specialty was virtually non-existent in early 80s. There was no formal fellowship program till 2008. Under late Dr. Marwa, the commencement of programs such as DM in pediatric hemato-oncology in reputed institute like PGI, Chandigarh in 2009 was an excellent beginning. I was lucky enough to work with him. He was my mentor, and I published a few papers with him. I want to remember him. Here you see Dr. Bharat Agarwal. He was the president of the Asia Pacific Hemato-Oncology Group meeting. In 2012, this was the first meeting in Indonesia. So we remember him also. He's our speaker. Well, hemato-oncology in UAE, I've shared this slide before. At Tawam Hospital, the pediatric oncology was started in 1983, even before India. And Dr. Thomas Rivers was consultant pediatric hemato-oncology. At Dubai Hospital, now they have shifted to Al Jalila Hospital. Dr. Abdulrahman Jasmi, senior consultant and head of department of pediatric oncology, is one of the pioneers, remember. Now our speakers, I have shared this with all. Everybody knows. Just briefly, I would like to introduce Our speaker, Dr. Vikas Dua. Dr. Vikas Dua is a pediatric hemato-oncologist and bone marrow transplant specialist at Fortis Hospital, Haryana, India. In different hospitals, he is working. Dr. Gua's result in the field of pediatric hemato-oncology and bone marrow transplantation have been one of the best. He and his team, please note, they have done more than 1,200 transplants. 400 of those are in children, rest in adults. He is known for his excellent outcome in stem cell transplantation, especially in pediatric, unrelated and haploidentical transplant, and he has done some of the very rare transplant which nobody else has done in India. So please listen carefully to his talk. He has a special interest in benign pediatric hematology, hemato-oncology, matched sibling, and unrelated pediatric haploidentical transplant. Okay, now I'm ending by a quotation from the Hippocrates. Especially this holds good for the hemato-oncology. Cure sometimes, treat often, but comfort always. Please comfort always. Well, these are my references. Beautiful Dubai. Once again, those who have not seen, I request them to come to Dubai. Now I would like to request our speaker, Dr. Vikas Dua, to start his talk. I would like to request all viewers to write the questions in the Q&A box after completion of his talk. With moderators, we'll start. Over to you, Dr. Dua, please.
Thank you very much, Dr. Sharab, for a really kind introduction. And before I start my talk, I would like to really thank from the bottom of my heart the Dubai Pediatric Club, Dr. Diary, Dr. Kalpana, and the rest of the team for giving me this opportunity to be here and giving a talk which is very close to my heart, because the journey of pediatric hematology, what I have lived in last 15-20 years, I'm going to discuss that. I'm going to put that in front of the viewers who are here, who are in the night hours, who are listening to us. So friends, the task given to me is to talk on hematology. Being a pediatric hematologist, oncologist, and a transplant physician, I'm going to talk a brief synopsis, which would be of use for all the pediatricians who are practicing either in UAE or throughout the world, so that from tomorrow, when they have a patient, a pediatric patient who has got a blood disorder, they can be more wiser in making a diagnosis and in treating that patient. That is what I'll try to do in next 1 hour. So friends, before I actually talk on anemia, thrombocytopenia, pancytopenia, means the common issues in pediatric hematology, I would just like to share 2-3 slides on my journey of pediatric hematology oncology. So friends, this is the institute which is called Sir Gangaram Hospital, which is in New Delhi, from where I started my training in pediatric hem-onc almost, I would say, 14 years back. So I was in this hospital. Those of you who know about Delhi, those who have been to Delhi or are from medical background must have heard about this hospital. And this is the place where I started my pediatric hem-onc fellowship. So Dr. Shorab just said that till 2008, there was no fellowship program in India, no formal fellowship program in India. And mine was a third batch. That means in 2010, I started my fellowship from this hospital, which is a renowned and a prestigious hospital in India called Sir Gangaram Hospital. So friends, as pediatric hem-onc was quite new in the country, no formal fellowship was there before 2008. So definitely pediatric transplants were also new. And after completing my fellowship in pediatric hem-onc, I wanted to learn about pediatric transplants. And unfortunately, at that time, there was no pediatric bone marrow transplant, or you can call it what Dr. Sharaf rightly said, the correct word is hematopoietic stem cell transplant. So there was no formal pediatric hematopoietic stem cell transplant fellowship in India. So I went to National University Hospital in Singapore, and the picture on the left is the day when I was leaving. I completed my fellowship
Your
in
voice is
Singapore.
not clear.
Oh, is it? Just a minute. Just a minute. Can you hear me now?
Yes, please.
All right. So the picture on the left is the day when I was leaving Singapore, the last day, and this is the picture of our bone marrow transplant unit when they were giving me a treat, and I left the very next day, and I came back to India, and I joined the hospital, which is on the right, which is in a place called Gurgaon, which is very near to Delhi. So National Capital Region, Delhi NCR region is this hospital located. And me and my colleague, who is an adult transplant physician or an adult hematologist, we started the transplant program in this hospital. And these are some of the pictures when we completed first 100 and 200 successful transplants in that hospital. Because at that time, very few centers in India. I'm just talking about not very long back, just a decade back. There were very few hospitals in India who actually into transplant. And then after being in that hospital for almost 3 years, this is my present hospital on the left, which is called Fortis Memorial Research Institute Gurgaon. And Fortis is one of the biggest healthcare programs in the country and has got around 27 branches in the country. And we are in the flagship hospital, which is in Gurgaon, just 20 kilometers from Delhi's international airport, where I'm working. And it's been almost 7.5 years that I'm in this place with a fantastic team of colleagues whom I am with. So, friends, as you all are pediatricians, majority of you are pediatricians, you are very well aware that pediatric hemonc training is a combined training in our country and in some of the countries in the West. And a pediatric hematologist look after the benign hematological part like anemia, thrombocytopenias, pancytopenias, bleeding disorders, look after the oncology part, whether it's a liquid tumor or a solid tumor. And some of us are into transplants, and there are indications of doing transplants like thalassemia, sickle cell anemias, aplastic, bad malignancies, primary immunodeficiencies, and nowadays we are doing transplants even for metabolic disorders. So friends, now the next part of the talk is a case-based discussion on the common hematological issues which we see. We all as I would say you all as pediatricians do at some point of time encounter patients like these who have pallor. And we all need to know that there is a definition which is being defined by WHO or CDC for anemia. So friends, we are not talking about severe anemia. We are talking just what a definition of anemia should be. For somebody who is between 6 months to 5 years of age, according to CDC, if hemoglobin is less than 11, you call that patient to be anemic. A child between 5 years to 12 years, less than 11.5 is anemia. And somebody who is a menstruating woman, a hemoglobin of less than 12 is anemia. So just understand the fact that a hemoglobin in a child who is of any age, maybe from day one of life to 18 years of age, which all of you see in your practice, if the hemoglobin is less than 11, something around 10, then we need to think what is the probable reason. We cannot just take it for granted and say hemoglobin 10 is fine. In Hindi, in India, we say 10 hai to bas hai. No, 10 hai to bas hai nahi hai. We need to understand anything less than 11. We should try to figure out what is the reason, what is the cause for that low hemoglobin. And when we all as pediatricians order a hemogram, a complete hemogram, other than the hemoglobin, white cells, platelets, it is very, very important for us to look at the indices. Friends, I know quite a number of you must be looking at the indices, must be looking at the MCV, MCH, MCHC, but those of you who are not looking at these indices, please try that from tomorrow, whenever you see a hemogram, you look at the indices, which is MCV, MCH, and MCHC. along with that RDW. If you see this along with the hemoglobin, white cells, platelets, and differentials, in majority of cases, you will be able to come to a conclusion. You will be able to answer what probable reason of low hemoglobin in that particular child is. And definitely nothing can substitute a peripheral smear examination. So you need to have a good pathologist, a good hematopathologist in your center who can see the peripheral smear and can help you in making a diagnosis. So how these indices help? This is just a slide which tells you that if you just look at the MCV and your MCV is low, the differentials which you should keep in your mind, which you all know, are iron deficiency, thalassemia, which is either alpha or a beta thalassemia, but the rare things like sideroblastic anemia, anemia of chronic disease, and lead poisoning. In all these conditions, the MCV is low. It's a microcytic hypochromic anemia, and these are the differentials of microcytic hypochromic anemia. We'll come to some cases after this PPT. And if in patient who has got a high MCV, friends, please remember that's a macrocytic anemia. That means probably it is a B12 or a folic acid deficiency, but sometimes in liver disease, in hypothyroidism, in adults like alcoholism, in certain patients of aplastic anemia, in certain patients of pure red cell aplasia, your MCV can be high. And the most challenging and difficult anemia, even for a hematologist, is a normocytic and normochromic anemia, in which your MCV is normal, and the common differentials are hemolytic anemia, or sometimes anemia of chronic disease can be normocytic normochromic. But remember, anemia of chronic disease can be normocytic normochromic or can be microcytic hypochromic as well. So friends, with that background, let's look at some of the case scenarios pertaining to anemia. So this is a 6-year-old child who's been brought to your clinic by the parent, and parents say that, oh, my child looks pale, doesn't look normal, looks white for almost a year. And then you examined the child and there was no organomegaly. The child was otherwise looking well, but was definitely pale. You ordered a CBC. I'll show you the CBC report. And it was a microcytic hypochromic anemia, and there was a RDW which was high. So a diagnosis of iron deficiency was made by you, and you started the patient on iron supplement, and it was continued for almost 6 weeks initially. This is the peripheral smear of the child, and if you see small cells, microcytic cells, hypochromic cells, but even after 6 weeks of the child being on iron supplement, the hemoglobin was not coming up, and somehow somebody just, we don't do that in our practice, but some other pediatrician just look at the ferritin again after 6 weeks, and the ferritin was very low. So this patient, you and somebody like us who's into pediatric hem will say that, yeah, this is iron deficiency. If you see the CBC report, initial report, a hemoglobin of 7.1 with white cells of 11,000, with normal differentials and thrombocytosis, with microcytic picture, with the MCV of 65 and a RDW which is high, will say we are pretty sure that this is iron deficiency. And you start these patients on iron supplement at a dose of 3 milligram per kg, and you expect a rise in the hemoglobin. But somehow in this child, even after 6 weeks of iron supplement, there was a marginal increase in the hemoglobin. There was still thrombocytosis which was persisting. So this is something in which the patient was not responding to oral iron therapy, which is not a common scenario. Majority of time, it's a nutritional deficiency. And if you start somebody on iron supplement, the patient start responding very soon. And those who don't respond, you need to see whether the compliance is correct, whether the patient is bleeding, probably because of Meckel's, some polyp, diverticula, some AV malformation, or is it an absorptive issue? So either the intake compliance is the issue, or as the iron gets absorbed from the duodenum, there is an issue related to absorption like celiac disease, tropical spur, or the patient is losing because of warmth, because of a diverticula, because of a Meckel's, ulcerative colitis, Crohn's disease can lead to IDA, and the patient is not responding. But in our case, this patient was found to have anti-TTG positive, anti-endomysial antibodies positive. Endoscopy was done, which confirmed the diagnosis of celiac. So this patient was not responding because he had celiac disease, he had a gluten-induced enteropathy. So if you make these patients gluten-free, if you avoid gluten in the diet and you start these patients on supplement, they start improving. And in general, if you have a patient who's an IDA, we always recommend a dose of 3 milligram per kg. Along with that, if in case you have worm infestation, dietary modification which is required, do that, and you have to continue for 3 to 6 months depending upon the response. So that was a classical case of IDA, but a classical case, but a one which was not responding to iron supplement because of an absorptive issue. Let's come to another case, friends. We will be taking your questions at the end of the presentation, and we'll be more than happy to answer those. This is another case scenario, 8-month-old boy who's been pale for last 10 days, poor appetite, otherwise having no fever. On examination has got a liver and a spleen which is palpable below the coastal margin. So hemoglobin, 8-month-old, hepatosplenomegaly, hemoglobin of 5.5, white cells high, 42,000, differentials okay, platelet okay. But if you look at the indices, so indices is a must. It's again microcytic. So this is not IDA. This patient has got hepatosplenomegaly, but this is microcytic hypochromic, again with the MCV of 62 with a high WBC. So, and what we have discussed is that IDA, thalassemia, sideroblastic, anemia of chronic disease, and lead poisoning are the differences. So in none of these conditions, you will find a high WBC. But why WBC is high in this patient? And there is some unconjugated hyperbilirubinemia, total serum bilirubin is 2.2, and LDH is high. Peripheral smear was seen by the hematopathologist, microcytic hypochromic, some target cells, basophilic stripling, lot of nucleated RBCs, and that's why the Coulter was counting those nucleated RBCs as WBC. So the actual WBC count was okay, but as the machine was counting the nucleated RBCs in the WBC, that's why in the Coulter report it came to be 42,000, but the corrected one is okay. And so that means this boy had a normal WBC count, nucleated RBCs, target cells, but a microcytic hypochromic picture with hepatosplenomegaly. So probably it's thalassemia, and the patient presented at the age of 8 months. So a HPLC, high pressure liquid chromatography, was ordered, which showed a very high HbF of 95.5% and confirmed the diagnosis of beta thalassemia major. Another scenario of microcytic hypochromic. Let's come to a different scenario. A 11-year-old female, strict vegetarian, and has come to your clinic and parents say that she's pale, lethargic, and you ordered a CBC. Not surprisingly, I would say the hemoglobin was very low, severe anemia of 4.2, but the TLC was also low with the normal differential platelets low. So it's a pancytopenia-like picture, but as compared to the other cell lines, the hemoglobin was very low. So as we discussed that in each and every case, indices to be seen. In this case, indices were not low, it was high. Look at the MCV, which was high, RDW also high. So what is the thought process? We have discussed that the first two common differentials in somebody who has got a macrocytic anemia, think of B12 and folic acid deficiency. And if somebody is a vegetarian, B12. The next step is always looking at the peripheral smear, glossitis, you see the nails, and you ask the pathologist to see the peripheral smear. There are macrovullocyte, hypersegmented neutrophils. Anybody would say that this is megaloblastic anemia. And to confirm whether it's B12 or folic acid, by the history, it looks like B12, but you can always do a B12 folic acid level. And in megaloblastic anemia, if you do LDH, please do LDH. LDH would be very high. In very few conditions in hematology, LDH is high. Other than hemolytic anemia, malignancy, you see high LDH in megaloblastic anemia because of the ineffective erythropoiesis and increased cell turnover in the marrow And if you start these patients on B12 folic acid, they show a reticulocytosis, they show increase in retic count. So my practice, when I see a nutritional anemia patient, whether it is an iron deficiency or a B12 folic acid deficiency, I do a baseline retic count along with the CBC. And after 3 to 7 days, you see a high retic. That means the patient is responding to whatever you're doing. And in patients of B12 or folic acid deficiency, those who have got pancytopenia, the thrombocytopenia, neutropenia, these things also start getting corrected after 2 weeks. Another scenario, friends, but this scenario is not microcytic. This is a macrocytic anemia. So we have discussed microcytic, macrocytic. Let's come to another scenario, which is normocytic, normochromic. 4-year-old male seen by the doctor when the mother noticed that the whites of the eye appear yellow and the child is passing dark colored urine. That means the patient has jaundice, high colored urine, probably some hematuria happening. Father also has a history of yellowish discoloration of the eye. So there is some genetic problem. Father also has yellowish discoloration of the eyes since early childhood. This child, 4-year-old boy, has jaundice, passing high colored urine, has got splenomegaly. A CBC showed a hemoglobin of 3.1, white cells normal, platelet normal. So a hemolytic process, probably a hemolytic process. At a retic count, which is high, of around 22%. But in hemolytic anemia, what we discussed, it's a normocytic, normochromic anemia. Next test is always a peripheral smear. Like in this case, all of us will be able to make a diagnosis that these are all spherocytes. And as the father also had similar history and hereditary spherocytosis, which has been an autosomal dominant disorder, we can very well say, even without doing osmotic fragility or a eosin-5 myeloid test, that this child is been suffering from hereditary spherocytosis and may require splenectomy. So friends, a journal approach to normocytic normochromic anemia is look at the retic count. If the retic count is high, if there is any evidence of hemolysis on the peripheral sphere, it's a hemolytic process. If there is no evidence of hemolysis, it might be a recent bleed. In case your retic count is normal or decreased in normocytic normochromic anemia, think of anemia of chronic disease. Think of chronic inflammation, a renal issue, endocrine issue. It might be anemia of chronic disease. If that is not the case and other cell lines being affected, it might be aplastic anemia, might be MDS, might be infiltrative disorder like a leukemia. And in some cases, you may have to do bone marrow investigation. So friends, those were the cases related to anemia. Let's come to the second common scenario, low platelets. Low platelets, another case for you. 6-year-old boy has come to you with history of bluish spots over both the legs for last 2 days. Bleeding from nose since morning. So for last 2 days, some ecchymotic patches over the body, epistaxis since morning. There is a history of fever, a viral process 4 weeks back, no past history, no family history. Otherwise, child looking absolutely well, afebrile, hemodynamic stable, has come to your clinic running, but on examination, ecchymotic patches, bruises all over the lower limbs, no hepatosplenomegaly. And you ordered a CBC with the hemoglobin of 11.2, which is quite okay, white cells of 6,500 with normal differentials, but platelets which were low. A normal child, 6-year-old, coming to your clinic running. Parents are worried that he has got some ecchymotic patches, bleeding since morning from the nose, history of viral process 4 weeks back, platelet of 8,000, normal coagulation, peripheral smear normal, few giant platelets. Everybody will say this is ITP. So making a diagnosis of ITP is not difficult. Managing, everybody has its own way of managing. So we'll come to that. How do you classify somebody who has got a less than 3 months duration of ITP? It's newly diagnosed, 3 months to 12 months, persistent ITP. And if it's going on, lingering on for more than 12 months, more than a year, it's called chronic ITP. Please remember these things, friends. What is not typical of ITP? Fever, bone pain, or joint pain at the time of presentation. You may have a history. You may have a history of joint pains. You may have a history of fever 4 weeks back, maybe a viral process 4 weeks back. But at the time of low platelets, this is not typical. Lymphadenopathy, hepatosplenomegaly, no, we don't see hepatosplenomegaly lymphadenopathy in a classical case of ITP. If you have that, think of something else. Family history, it's an idiopathic thing, maybe a viral process in the past, maybe a history of immunization past. So no family history. If you have a family history, it's not ITP. And other than that, abnormal hemoglobin levels. When I say that, if you have a patient who has just bled, let's say 2 drops from the nose and has got a hemoglobin of 7 with a normocytic normochromic anemia, it is something else. But in a country like ours, in India, we have quite a number of patients are nutritionally deficient. If a similar patient has got a 7 hemoglobin with microcytic hypochromic picture, then I can say that this is ITP with iron deficiency anemia. But I have normal hemoglobin level, which has not been you are not able to explain, is not ITP. And the idea of treating ITP is not to treat the platelet count. That's not the goal. The idea, the therapeutic goal in ITP is to minimize risk of serious hemorrhage, decrease the restriction of activities so the patient doesn't get hurt on the head, and exposure to toxic drugs is minimized. Avoid no NSAIDs to these patients. And when it comes to the treatment of ITP, the first line therapy, we all know steroids like prednisolone, IVIG, and in some cases NTD. Somehow NTD is now not available in our country, and the response rates are close to 70%. And the fastest acting is IVIG or NTD. So in 24 to 48 hours, with a 1 gram, 0.8 to 1 gram per kg of IVIG, you see a response. Whereas with prednisolone, at a dose of 1 to 2 milligram or maybe 4 milligrams, some people say you see a response in 3 to 7 days or 2 to 7 days. But the beauty of steroids is that it increases the capillary resistance. That means the risk of bleeding comes down. So it is important for a pediatrician to decide whether the patient requires therapy or not. But in our practice, somebody who has got mucosal bleed, we treat. And if it's just the skin bleeds, we just wait and watch. Because majority of patients, even if you wait and watch, look at the last slide. If you wait and watch, 70% to 75% patients will recover in 3 months. Very few will go into persistent or chronic phase. And the indications of treating these patients is a mucosal bleed, means epistaxis, hematuria, GI bleed, or if you don't have, open the mouth. Ask the patient to open the mouth. If you see wet purpura, bleeding spots in the mouth, that is an indication to treat. That's another scenario which we see as pediatricians or a pediatric hematologist in our practice. So friends, we have discussed anemia, we have discussed ITP. Let's come to a bleeding child. A bleeding child in which the platelets are normal and it's a coagulation issue. It's important to take a detailed history and do a thorough clinical examination before you order a CBC and a PT-APT. So friends, if you have a patient who has got a history of bleeding, maybe joint bleeds, normal PT and a prolonged APT, we all know that we have to think of hemophilia A and hemophilia B, which means factor 8 and factor 9 being low, which is an X-linked recessive disorder, and only males are affected and females are just the carriers. We will come to von Willebrand assay later, but in some patients of von Willebrand disease, you can have a prolonged APT. Why? Because von Willebrand being a carrier of factor 8, if your von Willebrand factor levels are low, the factor 8 levels get degraded, which leads to high APT. And if you have a patient who doesn't fit into hemophilia A or B, or von Willebrand has got a high APT, do a mixing study. It may be lupus anticoagulant. Then conditions in which your PT, APT both are prolonged, but platelets are normal. That means maybe a classical severities of newborn, a newborn who's been not given vitamin K because of vitamin K deficiency, liver disease, rare causes in which both PT, APT are prolonged. The common factors like factor 10, factor 5, thrombin deficiency, afibrinogenemia, dysfibrinogenemia. In these conditions, your PT is prolonged along with APTT. Next, a scenario in which child has bleeding, the PT is prolonged, but the APTT is normal. Just the PT prolonged, APTT normal, which can be a They're in early vitamin K deficiency, in liver disease, and a factor, no, not a common thing, but in factor 7 deficiency, this can happen. I have seen in my practice the 3 patients who got factor 7 deficiency, so it's not a common thing to see. Then a patient who's sick, low platelets, along with prolonged PT, prolonged APDT, a DIC lot of sort of scenario. But an important thing for all of you is a scenario in which everything is normal. Your platelets are normal, PT normal, APD normal. What to do? For that, we are going to discuss this case. 9-year-old boy presented with history of excessive bleeding after the removal of adenoids. On further evaluation, he was taken for a adenoid surgery and had excessive bleeding. And when a thorough history was taken later, it was found that he had recurrent episodes of epistaxis, which were mild in nature. There is a family history of menorrhagia in the mother. On investigations, the platelets were very normal, were 281,000. The PT was INR was normal, the APT was normal. So in this scenario, PT normal, APT normal, platelets normal, a past history of recurrent episodes of epistaxis, but now after the adenoids removal, the bleeding is not stopping. So what are the scenarios? The scenarios are something like this. Factor 13 deficiency, platelet function disorders like Lenzman's thrombocythemia, Bernard-Collier disease, storage pool defect, and in patients who have got von Willebrand disease. So not all patients of von Willebrand disease can have a prolonged APT. Sometimes this can be normal. So a scenario in which everything is normal, think of factor 13 deficiency, platelet function disorders, von Willebrand disease. Sometimes mild clotting factor deficiency can have a normal PT, APT, collagen vascular disorder, scurvy patients, vitamin C deficiency patients can have PT, APT normal, platelets normal. This patient, you can do a clot solubility test to look at whether they have got factor 13 deficiency or not. You can do a von Willebrand factor assay. You can do a Rikoff assay because sometimes your von Willebrand, the quantity is normal. That means it is not von Willebrand type A, type 1 or type 3. It may be a type 2 von Willebrand disease in which there is a qualitative defect for which you require a Rikoff activity assay and platelet function test in which you are suspecting platelet function disorders. So these tests are available in the country. I'm pretty sure you can get these tests done in UAE also in patients who have got a normal PT, APT, or normal platelet count. Our patient had von Willebrand disease. The mother had, if I go back to the case, the mother had history of menorrhagia. The patient had bleeding after adenoids removal, some epistaxis. Von Willebrand disease being an autosomal dominant disorder, you may have a history in the family, and this patient was diagnosed to have von Willebrand disease and was eventually treated, was given cryoprecipitate. Let's come to a different case scenario. So friends, anemia discussed, thrombocytopenia discussed, bleeding disorders discussed. Let's come to pancytopenia. 10-year-old girl, sudden history of onset of weakness and fatigue after recovering from 1 week of history of viral illness. The girl was absolutely all right 1 week back and now been having weakness, fatigue, tiredness, pale, no organomegaly, just 10 years old, 3.1 hemoglobin, a white cell normal, a white cell which were low of 2000, a differential which showed neutropenia and platelets were around 20,000. So this patient had pancytopenia, a low hemoglobin, a low white cell count, and a low platelet count. So this is pancytopenia. What to do? The next step is always a peripheral smear, and sometimes B12 folic acid deficiency patients can have pancytopenia. You can do that. LDH was done in this case. I'll tell you why. Retic count was done, which was low. And a bone marrow was ordered, which showed an empty marrow, and a diagnosis of aplastic anemia was made. So this is the most important slide for you. So when you have a patient who has got pancytopenia, you need to think of these 4 causes. The first one being a bone marrow failure syndrome. That means the bone marrow is not producing red cells, not producing white cells, not producing platelets, like in aplastic anemia. Now, aplastic anemia can be idiopathic, can be viral induced aplastic anemia, or sometimes it may be an inherited bone marrow failure syndrome, like Fanconi's anemia, dyskeratosis congenita, Schwartzman-Diamond anemia, amegarocytic thrombocytopenia. So in those cases, you may have a family history. Like the most common being Fanconi's, it's an autosomal recessive disorder. Two parents are carriers, and if let's say you have a consanguinity history and parents are carriers, then we can have Fanconi's. Second cause, ineffective bone marrow production, like ineffective erythropoiesis, like happens in megaloblastic anemia, B12 deficiency, folic acid deficiency, they can present to you with pancytopenia. If you have a marrow space occupying lesion, if you have bad cells like blast cells in the marrow, then sometimes these patients can present with pancytopenia. It's not that each and every case of pancytopenia, each and every case of leukemia will have blast in the peripheral smear. There are patients in which your marrow is clogged with blast and they come to you with pancytopenia like picture. And if your marrow is normal, otherwise you don't feel that it is B12 folic acid deficiency or it is leukemia, then it may be a peripheral destruction of hematopoietic cells, like happens in autoimmune disorders like SLE. So friends, please remember, if you remember this slide, I'm pretty sure in majority of cases you will be able to make a diagnosis. Then whenever it comes to aplastic, I always urge everybody that transplant is a better option. Why it's a better option? Because transplant works faster. In 14 to 21 days, the hematopoietic system is normal, the hemoglobin is normal, the white cells are normal, the platelets are normal. Whereas if you give these patients immunosuppressive therapy like ATG, cyclosporin, and sometimes people add TPOs like thrombopoietic analogs like Revolade, Romiplastin, it may take 3 to 6 months. Patient would be at risk of infections, would be at risk of bleeding, and you may have a complication even after giving these medicines. So it's important that if you can do an early transplant of the aplastic anemia patients, that is always better. Another scenario, friends, another important scenario for those of you who are working in ICUs. Another, I would say, pancytopenia case, but important for those people who are in ICUs. 2-year-old male, the history of fever for last 10 days. And a CBC was done, which showed pancytopenia, liver functions were deranged. Child was initially stable, but then had a hemodynamic instability, had a diffuse rash over the body, examination, lymphadenopathy, hepatosplenomegaly were present, had bilateral bronchi, creps in the chest. So he was septic. Was having sepsis, pneumonia, hepatosplenomegaly, lymphadenopathy, initially stable but was later sick, and pancytopenic with deranged liver enzymes. Hemoglobin of 6, white cells of 2000, and a platelet of 16,000. Another scenario of pancytopenia, deranged LFT. Other markers of inflammation were raised. So what will you think? Do you think that this is sepsis? Do you feel that this is DIC? Is it a new entity called HLH, which I'm pretty sure majority of you know by now, hemophagocytic lymphohistiocytosis, or it is none of the above? So friends, please remember that a patient who looks septic, who has got pancytopenia, has got hepatosplenomegaly, and deranged liver functions, it might be a sepsis-induced hemophagocytic lymphohistiocytosis. And if you have 5 out of these 8 points, you can very well say that there is HLH going on. If the patient is febrile, has got a splenomegaly, has got at least bicytopenia, has got hypertriglyceridemia or hyperphagocytemia. So this is 1 point. Has got evidence of hemophagocytosis in the marrow, has got a ferritin more than 3000, elevated IL-2, RA more than 2400, or a decrease in NK cell activity. So friends, I know that last 2 tests might not be possible for everyone. To make it simple, if I say that if you have a patient who has got fever, who's been sick, has got hepatosplenomegaly, lymphadenopathy, and has fever, splenomegaly, that means 2 points are there. Third is cytopenic, means is bicytopenia or pancytopenia. Third point, do at least ferritin, triglyceride, and fibrinogen. If your ferritins are high, that means the fourth point. And along with that, if your triglycerides and or fibrinogen, triglycerides high and or fibrinogen low, you can say that this is pancytopenia, this is HLH. And if you have facility, if you can do a bone marrow, then sometimes you can say evidence of hemophagocytosis in the marrow, and these patients would require something on top of the antibiotics, means may require therapy in the form of steroids, cyclosporin, and etoposide to control the hemophagocytic activity. And the common causes of HLH are acquired ones like infections, malignancies, or a autoimmune disorder, in which the common terminology used for these HLH patients is macrophage activation syndrome. But sometimes HLH can be familial. Usually it's an autosomal, I would say, recessive disorder, and we have seen in our practice quite a number of familial HLH patients also. This patient had a ferritin of 1300 initially, and it increased to 18,000. Triglycerides were high, bone marrow hypocellular with evidence of hemophagocytosis. So friends, anemia, pancytopenia, thrombocytopenia, bleeding discussed. Let's come to another scenario. 5-month-old boy with fever, cough, rapid breathing. Just 5-month-old, has fever, cough, rapid breathing, oral thrush before the onset of illness. Doesn't look like to have HIV, but still HIV was done and it was negative, WBC normal, and lot of infiltrates in the chest. Absolute lymphocytic count was low. This patient had immunodeficiency, severe combined immunodeficiency. If a patient comes to a clinic with failure to thrive, recurrent pneumonias, recurrent oral thrush, otitis, think of something else. It's not a, I would say, normal child who's been coming to you again and again. He or she might be having immunodeficiency. At least do a immunoglobulin profile, lymphocyte subset, and you can pick these patients early, and you can refer these patients for a transplant to a specialized center. And it is, if you remember these 10 warning signs of PID, I'm pretty sure in majority of cases you'll be able to pick these patients early, which means point number one is 4 or more new year infections within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months of antibiotics with little effect, 2 or more pneumonia episodes happening in 1 year, a child who is not thriving well, somebody who has recurrent deep skin or organ abscesses, somebody who has got persistent thrush in the mouth, somebody who needs intravenous antibiotic for a long time to clear the infection, somebody who has 2 or more deep-seated infections, including septicemia, and the most important one, if somebody has got a family history of PID, please refer these patients to a specialized center. And there are different types of PIDs which are known. More than 300 PIDs are known at the present moment of time, and they are categorized into 8 of these categories. One is combined B and T cell immunodeficiency. Second one, predominantly antibody deficiency, and some immunodeficiency syndrome, some immune dysregulation diseases, complement deficiencies, autoinflammatory disorders, defect in the innate immunity, and some congenital defects of phagocytic number and function. So these are some of the PIDs which are known. Let's move on to the last part of the presentation, which is very, very close to my heart, and which is bone marrow transplant. So Dr. Shorab already said that in 1968, the first successful sibling donor transplant was performed by this person, who is a pioneer, who is the father of bone marrow transplant, Dr. Thomas, and he was the one who performed the first successful transplant for thalassemia also, which is a very common problem in India, because India is the thalassemia capital of the world. And because of his fantastic work, Dr. Thomas got a Nobel Prize in 1990. He received a Nobel Prize. This information is also shared by you all with Dr. Shorab, and we all have due respects for Dr. Thomas, because he's the one who did the first successful bone marrow transplant in the world. And as pediatricians, friends, you just need to know these indications. I'm not going to go into the detail. I'm not going to bore you. I'm just going to tell you the common indications of doing a hematopoietic stem cell transplant. It may be a malignant disorder like a relapsed leukemia, a myelodysplasia, a relapsed lymphoma, iris brain tumor, or a metastatic neuroblastoma. But the point which is important for you is the non-cancerous and non-malignant indications like aplastic anemia. I've already discussed on that. Inherited bone marrow failure syndromes, Fanconi. In these patients, ATG doesn't work, so you have only one choice, which is transplant. Immunodeficiency. Please refer immunodeficiency patients early to a transplant center because if you don't do that, these patients may not survive long. Sickle cell. Quite a number of people in Africa are suffering from sickle cell, and the only cure is a transplant. Gene therapies are still under trial. Thalassemia, very close to our heart because India is the thalassemia capital of the world. A lot of thalassemics are there in the country, and the only cure for these unlucky kids is a transplant. And nowadays, for certain metabolic disorders also, transplant doctors are doing transplants. So friends, it is not a surgery. In movies, people see and feel that it's probably the transplantation is going to break your bone or it's a major surgery. No, it's a very simple procedure. It's like transfusion which is happening to a patient. It's like a blood transfusion which we do, but I'm not going to go to the detail of the bone marrow transplant. But don't go by the movies or what somebody else say. It's the easy way. I always say hematopoietic stem cell transplant is not a luxury. People say that it's a luxury. No, it's a necessity. If you require it, then you have to go for that. And in our center, we have done more than 1,200 transplants, and this is a picture when we completed our successful 1,000 transplants more than a year back. And friends, I would say that this is not possible without a good teamwork. People who have stayed with us, who are a part of this journey with us, are always very close to our heart. And this is not possible without a good teamwork. Together, we can achieve more. That's what I always say. And you people, being pediatricians, being the first point of contact to these patients, I think you are the one who can refer these patients early to a center which has got expertise in doing transplant because you are the first point of contact. And definitely you can help these families in post-treatment care in the form of vaccination, and you can work closely with the pediatric hematologist in providing the care after the transplant what these patients need. So friends, with that, I would like to end my presentation, and I think I've finished on time because the time allotted to me was 45 minutes. And with that, I would like to thank you all for a patient hearing. With that, I will stop sharing the screen. Thank you.
Thank you very much, Dr. Vikas, for excellent presentation. I mean, fundamentals of pediatric hematology was discussed. I'm sure all viewers benefited. We have about more than 500 viewers watching from different countries. Now I'd like to request Dr. Diari, Dr. Kalpana, and if Dr. Joshi is there to join, I've requested Dr. Karimi, a pediatric hematologist from American Hospital, to join us also for discussion. Now I'd like to request Dr. Diari to start. Welcome, Dr. Karimi. Dr. Karimi is the senior consultant pediatric hematologist at American Hospital. He was in the United States, and I've requested him to join us for the discussion. Dr. Diari, please.
Yeah, thank you very much, Dr. Dua. Thank you very much for your nice presentation. Myself, as a pediatric surgeon, I learned a lot from your presentation tonight. Thank you very much. We have a couple of questions in the question and answer box, and we have from the WhatsApp group also. So we are categorizing them according to your presentation: iron deficiency, anemia, ITP, and then the transplant. So Dr. Khadija asking, is a Metzner index still a useful tool to differentiate between thalassemia and iron deficiency anemia?
Absolutely. So Menzer index is very important tool to differentiate between iron deficiency and thalassemia minor. Let me just try to make you understand. You have a patient who has got microcytic hypochromic anemia, and you know the differentials like iron deficiency, thalassemia, sideroblastic anemia, anemia of chronic disease, and lead poisoning. The last three are not very common. The first two are the common ones. Thalassemia major patient, you can very well diagnose because they present very early in their life, between 6 months to 1 year of age. Hepatosplenomegaly, low hemoglobin, you can very well diagnose. The challenge sometimes comes between diagnosing a patient who has got iron deficiency from thalassemia minor, because thalassemia minor patients, they have usually mild anemia, hemoglobin between 9 to 10.5, and a microcytic picture. In those two categories, iron deficiency and thalassemia minor, Menzer's can help. Menzer's is what? Is MCV divided by your RBC count. So if you have a low MCV and a low RBC count, that means your Menzer's is less than 13, goes in favor of your if that's low, goes in favor of IDA. If that's high, that goes in favor of thalassemia minor. So please remember, Menzer's is very important because your MCV is low in both the conditions, but your RBC count is high in thalassemia minor, whereas it is low in IDA.
Thank you. Next question is, how do you approach the management of patients with symptomatic iron deficiency anemia who is intolerant to iron? That means such as patients who cannot tolerate oral iron.
So that's a very important question. So whenever you have a patient who's got iron deficiency anemia, we always say that you have to take iron empty stomach. Empty stomach means there should be a gap of 1 to 2 hours from the food. Please don't take it with milk, because in milk you have calcium, and calcium decreases the absorption of iron. So you need to have a gap. But if you have patient who's been intolerant, who's been not tolerating iron well, in the form that he's got diarrhea, constipation, nausea, vomiting, so my practice is you give it with the food. This is not written anywhere. You will not find this in books. Please listen to me. If patient is not tolerating, give it with food. The absorption might be less. It may take more time for the patient to recover his anemia, but will tolerate. And you may not have to move on to the parenteral iron, because parenteral iron has got its own problems. Our adult colleagues, our adult hematologists, I would say adult physicians are very fond of using IV iron, but we pediatric hematologists, I can count on my fingers how many times I have used IV iron. So if somebody is intolerant, try to change the preparation, try to give it with food. I'm pretty sure in majority of cases that will help you.
So the dose will be also 3 milligram per kg per day, or
absolutely
6?
Absolutely. There was a time when people used to say that the prophylactic dose is 3 milligram per kg and the therapeutic dose is 6 milligram per kg. But now prophylactic and therapeutic is 3 milligram per kg.
Thank you. Dr. Karimi, do you have any question?
No. Thank you very much. It's very, very excellent topic, and I appreciate it, doctor. Regarding some cases of that you presented, I would like to add some comments. In terms of the Menster formula, because it's very easy to calculate MCV divided by red blood cell count less than 13, and MCH in another index divided by red blood cell less than 3.8 also, along with high red blood cell count, completely suggestive of thalassemia minor, vice versa, suggestive of iron anemia. But in terms of the iron anemia versus thalassemia minor, we consider in our Gulf region the three important diseases sometimes present with microcytic hypochromic anemia, and when we should differentiate all of these three diseases from thalassemia minor and iron anemia. Why? Because these three diseases, given iron is contraindicated. These are sickle thalassemia, hemoglobin H disease, and beta thalassemia intermediate. All of these three diseases categorized as a thalassemia intermediate syndrome, and they also present with microcytic hypochromic anemia, just like IDA and thalassemia minor. how to differentiate. If just check CBC, NRBC, look at the blood film review. If the NRBC seen in peripheral blood and splenomegaly and jaundice is very, very important. These three major alarming that just guide us to these three diseases: sickle thalassemia, intermediate beta thalassemia intermedia, and hemoglobin H disease. If all of these three symptoms, I mean, that three signs and symptoms, splenomegaly, jaundice, and NRBC, nuclear blast in the peripheral blood seen, just the next step is to go for electrophoresis to confirm all of these diseases are there or not there. This is very important because these three diseases, given iron, is contraindication because these three diseases increase intestinal iron absorption, and over time, gradually, they will develop iron overload. So this is very important.
Thank you very much.
Absolutely. I totally agree.
Yeah, Doctor, you mentioned there was a question that if a patient does not accept iron at all, neither oral nor IV, how you approach? Dr. Diari also has joined us. In your absence, I asked one question. So how do you approach? Iron by no means is accepted. So how you
Yeah, so I got your point, Dr. Shorab. So that means if you have a patient who is still intolerant to oral iron, even after doing the modification, what will we do? Yes, in those cases, if it's required, we will go with the parenteral formulation, and parenteral formulation.
If he doesn't accept parenteral also.
Yeah, so that does happen because we have seen in practice very few patients developing anaphylaxis. I'm sorry, but we have seen anaphylaxis happening with parenteral iron. In those patients, neither you can give oral nor you can give parenteral. And if you have somebody who has got a very low hemoglobin, then the only thing left is a blood transfusion and nothing else.
Okay, Dr. Fadl Najjar is asking how common are iron deficiency with children having worms, and what are the indicators for deworming children?
Yeah, I think that's a very good question. So if in our practice, we do see patients who have got worm infestation. If somebody is being started on iron supplement, is not responding, then we look at the causes. The cause has been an absorptive issue or worm infestation. And it's a common practice that we do a stool routine, a stool culture, and stool for occult blood for 3 consecutive days. And in those tests, if you find a worm, because of the worm infestation, because of hookworm, and sometimes because of pinworms, you can have some degree of bleeding going on. And because of that, you have iron deficiency anemia. So you may have to deworm, you may have to give these patients mebendazole, albendazole, and the dosage, I think few pediatricians know better than me. Less than 2 years, we give 200 milligram, but somebody who is more than 2 years, we give 400 milligram. And depending upon the worm infestation, you decide whether you want to give for 1 day or for 3 consecutive days albendazole.
Okay, moving on to thrombocytopenia. How would you manage a pediatric patient with immune thrombocytopenia who has severe thrombocytopenia without bleeding symptoms?
Yeah, so Dr. Diari, I in my presentation, I said that if you have a patient who has got ITP and doesn't have got mucosal bleed, just the skin bleed, even at a platelet count of 8,000, 10,000, I will not treat, provided the family understands. I give you an example. Let's say you are sitting in Dubai and you have a family who has come to you from Dubai itself and has got a child who is, let's say, 6 years old and who has got some bleeding spots over the body, and the platelet count are around 6,000, 8,000. And I would say a family's understanding, educated family, I would say, you counsel that the patient and you have already examined, there is no epistaxis, there is no history of, there's no significant history of epistaxis, no hematuria, no GI bleed, and you have examined the oral cavity that there are no pedicle spots. So that means you are sure that there is no mucosal bleed, and the family is from Dubai. You can counsel, you can say that they can wait and watch, they can see They can just follow the simple instructions that they should not give any medicines without the prescription, means no NSAIDs. They should try that child should not get hurt. And in case of a mucosal bleeding, they should come to the hospital immediately. And then if that happens, you can treat the patient with steroids or IVIG. But in case the family is a bit reluctant, is coming from far, then definitely you don't have a choice. You cannot just send the family in. They are not understanding. They're living far, and you say that I go by the book that there is no mucosal bleed. I will not treat. So in that case, you have to take a call whether you want to treat or not. So, but our practice, our Indian Academy of Pediatrics says that if you don't have mucosal bleed and you discuss with the family, they understand that yes, wait and watch is also an approach. And in many cases, the antibodies are going to disappear on their own. The platelets are going to rise in next some time. Then you can just follow the wait and watch policy.
Regardless of the count, because we have a neonate without any bleeding with 1,000, and he had intracranial bleeding. So
neonate might not be ITP, Dr. Diary, it might be something else. So I'm talking about ITP. In a different scenario, you have to go by the recommendation.
okay, so another question for treatment of ITP. What should you add to dexamethasone to achieve the fastest recovery in a patient waiting for a procedure, for example, for surgery or for anything?
Oh, that's a very good question, because sometimes people like you who are surgeons who encounter patients who have got low platelets, and you know that this is ITP and you want to bring the platelet count up faster. So what you said that with dexamethasone, what should we add so that the platelets come up early and a surgeon can do a surgery? I will put my bet on IVIG, because IVIG is the fastest acting. The book says that in 24 to 48 hours, 70 to 80% patients will have a response. In my practice, I have seen response happening even after 12 hours. So if you have a patient who has got low platelets, who's been planned for a surgery, and you want a high platelet very soon, you want a faster recovery, you give 0.8 to 1 gram per kg of IVIG, and sometimes in 12 hours, the platelets rise and the surgeon can do the job.
Okay, there is a question from the question and answer box. How can do bone marrow if a platelet less than 50,000?
Oh, people feel that you need to have a threshold to do a marrow. You need to have a platelet threshold to do a marrow. So I differ. I say that even at a 0 platelet count, you can do a bone marrow. It's not a vascular structure. Trust me, nothing will happen. We have done bone marrows at 1,000 platelet count, because the lab doesn't report a platelet count less than that. If you have a patient of any issue who has got a platelet count of whatever number, you can safely do a marrow, provided he or she doesn't have any other bleeding disorder. If you're sure that this is just a low platelet problem, go ahead and do a marrow. Nothing will happen. I can bet on that.
Dr. Zarab?
Yeah, one question. See, Dr. Vikas, they say 1 in
Yes,
8 patients with the epistaxis, they have 1 milligram. We see many cases. How you approach it? We have many cases of epistaxis, and 1 in 80. I mean, the incidence is high. How you approach these patients?
Oh, that's another very good question, because in our practice also we see quite a number of patients who come to us with epistaxis. So if you have a child who has got epistaxis, as a hematologist, you will ask the family history, you will ask the history of bleeding from any other side. But if that is not there, first and the foremost thing is to rule out a local cause. You need to send this patient to an ENT specialist, take the opinion of the ENT specialist that there is no local cause, because there are times when you, from the Little's area, the patient does nose pricking and they repeatedly come to you. If a local cause is ruled out, then it's your job. Then you approach like you approach any patient of a bleeding disorder, do a platelet count, a PTNR, APDT, and if any of these is deranged, treat accordingly. If your platelet count is normal, PT normal, APDT normal, then you have to think of a scenario in which these things are normal and you still suspect a bleeding disorder like factor 13 deficiency platelet function disorder or von Willebrand disease.
One more point, Doctor, regarding the PT and PT normal, in addition to these three important factor 13 platelet dysfunction, von Willebrand disease, there are other two very rare cases, alpha-2 antiplasmin deficiency and plasminogen activator inhibitor deficiency. This is too rare. I had only one case of alpha-2 antiplasmin deficiency, is a young teenager coming with menorrhagia, and finally the sample sent it to Italy, and then in the Milan, this discovered is alpha-2 antiplasmin deficiency. So sometimes it's alpha-2 antiplasmin deficiency, also the PT, PTT, all the coagulation assays normal, just like factor 10 deficiency. We should take it into consideration. Yeah. The other point, as you mentioned about the local anatomical problem for the epistaxis is specific. If Dr. Sorab is a unilateral nasal bleeding, most likely we should thinking about the local problem, because for the bleeding disorders, usually the nosebleed is bilateral, not only unilateral nosebleeds.
Thank you.
Okay, Doctor, in which platelet function disorders would you consider use of Novo7 as opposite to platelet transfusion?
So in majority, so the common platelet function disorders which we see in our practice is Glenn-Mann's or Bernard-Collier, though these are also very rare. So all of us, all the pediatricians need to understand that there is a defect in the platelets clumping. The number is normal. It is not a quantitative defect, it's a qualitative defect. The easier thing to try in these patients is to try with local measures like tranexamic acid, local application. If that is not controlled, transfuse platelets. Transiently, if you transfuse normal platelets, then that will help in clumping of these platelets and the bleeding will stop. But in case the local measures transfusion is not helping, then you need to have an agent like factor 7, which is NOVA7, to control the bleeding. So I would say I will start any patient who has got a platelet function disorder with, if it's a local bleeding like epistaxis, try to control by local measures, by just putting a gauge of tranexamic acid tablet. Sometimes we dissolve in water, and if it's a gum bleed, we try to apply it over that. If the local measure doesn't fail, then we give platelet transfusion. If nothing is working, then the option left is a factor 7. But we all need to understand factor 7 has got a very short half-life. It just has got a half-life of 2 hours. It can quickly act, but it's not going to be a long-lasting thing.
So you answer this question. You answer that question online. Is there any role of cyclocapron in ITP management?
Which I'm sorry, what is the question now?
Cyclocapron, tranexamic acid, cyclocapron. Is there any role of
ITP? I don't think so. You can just use the local control in case you require that. Otherwise,
in fact, tranexamic acid can be used in any chronic mucous membrane bleeding. Just tranexamic acid is contraindicated in hematuria. In hematuria, sometimes is a relative, not absolute, in hemarthrosis. Otherwise, in any kind of the mucocutaneous bacterium, we can use the tranexamic acid.
That's a very good point. I totally agree with Dr. Karimi that if you have a patient who's got hematuria, don't give tranexamic acid, because you can have a clot formation and you can have a urinary retention. In that condition, please don't use tranexamic acid, but in any other bleeding disorder, you can use. Thank you very much.
Okay. Are there any reasons to consider a prolonged course of steroid with taper over a short course of pulse steroid in the management of the ITP?
Yeah, I think we can use that. Depending upon case to case, you can use a prolonged course of steroid. Sometimes a patient who's been coming to you with recurrent mucosal bleed and doesn't have money, or doesn't want to go for the second line therapy, or doesn't have money to go for a IVIG sort of thing, then you can give short courses of steroids or a prolonged course of steroids in those cases, but not a usual practice.
What additional testing, if any, should be performed for an adolescent patient with heavy menstrual bleeding and a negative von Willebrand disease evaluation?
Oh, that's another interesting question, because if somebody has got menorrhagia, heavy menstrual bleeding, and as a hematologist, you have ruled out von Willebrand disease, then definitely that patient should go to a gynecologist so that a gynecological cause can be ruled out. And if a gynecological cause is ruled out and it's not von Willebrand disease, then what we discussed, that platelet function disorders and these type of problems can lead to menorrhagia.
Is there a role for anti-neutrophil antibody testing in the workup of neutropenia?
Yeah, it's not a common thing in India. Somehow, anti-neutrophilic antibody test is not available. But yes, if you're suspecting somebody to have autoimmune neutropenia, then anti-neutrophilic antibody test can help. And if that is positive, then you can give these patients IVIG the way you treat ITP. You can give in autoimmune neutropenia, the dose of IVIG is 1 to 3 gram per kg you can use for these patients. I'll give you an example. I had recently a patient who is a post-transplant patient, transplanted for aplastic anemia, but somehow he's otherwise doing well. After 4 months, his TLC was low, his neutrophils were low, but hemoglobin, platelets are normal. Just there is a neutropenia which was going on. The child is looking well. The way ITP patients look clinically well, just the platelets are low. In this case, the patient was well, hemoglobin platelets were normal, but the TLC neutrophils were low. So I inquired whether we can get anti-neutrophilic antibodies done from somewhere or not, but somehow the test is not available. I was strongly suspecting it to be autoimmune neutropenia. So I counseled the family, either do a marrow. If you do a marrow, there would be a lot of neutrophils, and we can say that probably there is a peripheral destruction going on, and then we can give a IVIG. Or if you're not willing to get a marrow done, there is no harm in giving IVIG. We give 1 gram per kg of IVIG for 2 days. And if your neutrophils increase, that would be an indirect way of proving what we are thinking of. And we gave IVIG, and next 4 days the neutrophils normalize. So yes, there is a role of anti-neutrophilic antibodies, but not in each and every scenario. You can just give IVIG and that can help.
No, because to give rest to Dr. Diay, I'd like to present Dr. Vikas, later on Dr. Karimi also, and give her. See, many physicians know also, as soon as hemoglobin comes below 10, 8 to 10, they go decide for blood transfusion. I would like to, because now the trend is to avoid giving blood transfusion. No, as a pediatric hematologist, I would like to, use this platform to tell our pediatrician when to use blood transfusion, what is the absolute indication of blood transfusion in anemias, what are hazards of that. Because once you give blood transfusion, you can't do anything, you don't know what is going on. So you please enlighten us on this, because many pediatricians, still I see at the hemoglobin 8, they give blood transfusion. You please tell us.
That's a very important point. I always tell in all the meetings that it is important to figure out the cause. Even if, let's say, majority of patients who have got anemia, the cause is nutritional. Even at a hemoglobin of 4, if you have iron deficiency anemia or a B12 deficiency, we treat. The moment you start iron, B12, the hemoglobin starts improving. So I always say that unless and until the patient has come to you on a stretcher, whatever the indication is, don't give a transfusion. If the patient is walking, even at a hemoglobin of 4, 5, has come to your clinic walking, try to figure out the cause rather than being in a hurry to transfuse, because sometimes after the transfusion, you may not be able to make the diagnosis of that patient.
Yes.
So try to avoid transfusion as much as possible. I hope Dr. Karimi will also agree to me.
Yeah, completely total agree, doctor, because even if, for example, iron anemia, hemoglobin 4 and over 4, asymptomatic, just treat iron, no transfusion. Why?
Absolutely.
Transfusion. And according to the United States Blood Bank Organization, said the safest blood is no blood transfusion. It's very interesting.
Absolutely.
The safest blood is no. So we should avoid giving transfusion as much as we can. This is a general rule.
Dr. Dua, in your classification, you wrote anemia from 0 to 6 years should be 11 and above. Now we have a lot of patients, not neonate, 2 months, 3 months, premature baby, 2 months, 3 months, coming for hernia, which is a bloodless surgery. But the anesthetist likes to have a hemoglobin above 10 or 11. And they are saying that, as we know, as an oxygen carrier, it needs hemoglobin. So what do you advise? We don't want to give blood transfusion, but hernia sometimes is emergency. We cannot wait for months to increase his hemoglobin by iron.
I got your point, Dr. Diary. So neonatal period or infantile period, majority of time, it is the physiological anemia of infancy. Because you people being pediatricians, you see physiological anemia in infancy in somebody who's a preterm between 5 to 10 months, 5 to 10 weeks. You have a nadir. You have a nadir of hemoglobin. Similarly, for somebody who is a term baby, the nadir can be a bit later. So you can accept that low hemoglobin. Start those patients on iron, because that will prevent the secondary, the later onset of anemia in these patients. And go ahead, if the surgery is required, go ahead. That is not going to cause any problem, because majority of cases are physiological and you don't need to be worried. So my request to everybody, to the anesthetist also, is that not to be in a hurry to transfuse these patients.
Okay. What you prefer as a preparation for before surgery? For example, you have sickle cell anemia, you have thalassemia, you have G6PD deficiency. Can we do them as a daycare surgery, or they should be admitted one day for some assessment? What's your approach?
So, Dr. Diary, each and every case is different. If you ask me for a thalassemia patient, you can go ahead with a daycare surgery. Just make sure that the hemoglobin is, you transfuse hemoglobin before you proceed ahead with the surgery. Sickle cell, it's a different case scenario. Sickle cell, your HbS levels are high. These patients are prone for crisis. During anesthesia, you can have crisis, you can have issues. So better you give IV fluids. You admit these patients a day before, give IV fluids, proper hydration, oxygenation to be maintained, and try to bring down the HbS level low. You need to have a HPLC report before you do that. And if your HbS levels are high, try to do a partial exchange transfusion or maybe a phlebotomy to bring down the HbS level, so that you can safely go ahead with the surgery. So for thalassemia, the approach is maybe a daycare. For sickle, admit a day before, do the IV, give the IV fluids, maintain oxygenation, do a phlebotomy or a partial exchange transfusion, then do a safe surgery. And then in G6PD, I think there is, you just avoid the stress, avoid the agents which can further exacerbate. Yeah, and try to maintain a hemoglobin of around 10.
The United States Sickle Cell, as Dr. Erika said, United States Sickle Cell guidelines said for the sickle cell patient, the hemoglobin should not be over 10. It's very important because of hypercoagulated states in sickle cell patients.
So whatever I'm missing, I'm really grateful that Dr. Karimi is there with me to save me.
No, thank you so much. Your talk's completely. Sorry about that. No.
Dr. Amir is asking, we need the splenectomy for hypersplenism, but surgeon not willing until platelet count is above 50. See,
the surgeon and the physicians both need to understand and have to come onto a common platform, because if you have a big spleen, that is a reason for thrombocytopenia. That is the reason for pancytopenia. Hypersplenism is the reason for pancytopenia. So if the surgeon wants a platelet count more than 50,000, you transfuse and get the surgery done. And after the surgery, everybody will be surprised because the patient will eventually have a thrombocytosis rather than have a thrombocytopenia.
Yes, exactly. So we are preparing for splenectomy, but we are asking the hematologist to advise for the vaccination. So what kind of vaccine should receive, and what's the time between the vaccination and the surgery?
I think that's another very important question which you have asked me, Dr. Diary. If you have a patient who is going to go for an elective splenectomy, there are two different scenarios: elective and emergency splenectomy. Elective splenectomy, that means you have a time, at least 4 weeks. At least 4 weeks before you take the patient for splenectomy, you need to give the patient some vaccines against encapsulated organisms like H. influenzae, pneumococcal, H. influenzae, meningococcal, and some centers even give a typhoid vaccine before taking the patient for a splenectomy. But there is another organism called Babesia. Babesia can also happen to a patient post splenectomy, but there is no vaccine. So H. influenzae, meningococcal, pneumococcal, and typhoid is what I recommend at least 4 weeks before splenectomy. And if you have a different case scenario, like you have a emergency splenectomy
Trauma.
because of maybe a trauma, then
Yeah.
even a day before, you don't have a choice. There is no harm. Give vaccination a day before and take the patient for surgery, whatever that benefit is going to happen. But at least you should give vaccination in those patients also.
Thank you.
What do you say, Dr. Karimi? This is my thought.
For the elective surgery, also in some references mentioned 2 weeks before surgery for example, pneumovax and Prevnar 30. 2 weeks. 4 weeks is fine, but at least 2 weeks before surgery should be vaccinated. Yes.
Absolutely.
So, do you suspect iron deficiency anemia in thalassemia patient if RDW is high?
Oh yes. So in somebody who has got a beta thalassemia minor, so thalassemia major and intermediate cannot have iron deficiency, but a thalassemia minor patient can have a superimposed iron deficiency also. I give you an example. Let's say a patient has come to your clinic, has got a hemoglobin of 7, MCV low, a high RDW, and you feel that there is IDA, and you start iron supplementation. Even after 3 months or maybe 3 to 6 months of iron supplementation, the hemoglobin is still around 9.5, 10. You know that you have treated that patient well, you have given the iron supplement, your diagnosis is correct, but still the hemoglobin is 9.5, 10, and the MCV is still low. So in those cases, it might be a superimposed iron deficiency on top of beta thalassemia minor. So you need to do HPLC to prove what you are thinking of.
So
the question
we have some cases of, as the doctor said, combined iron deficiency anemia and thalassemia minor. So we should be very careful. And RDW also shows anisocytosis. And then in iron deficiency anemia, we know that because of severe anisocytosis, the RDW is high. But in some cases of thalassemia minor as well, because of overactivity of bone marrow, it depends on the type of the thalassemia minor. In some cases, because of hyperactivity of bone marrow, also we can see anisocytosis and high RW. So RW normal or increased, we can see in thalassemia minor, but definitely in IDA anemia, RW is high. But as doctor said, I had a research, not now, 10 years ago, 10 to 12 years ago, that 7% in my research, 7% of the people had both combined iron anemia and thalassemia minor.
I want to interrupt. As these patients are coming low MCV, high RBC, low iron ferritin, the lab said do electrophoresis. We do electrophoresis normal. We know alpha thalassemia is also there. So the patients who cannot afford to go for alpha chain analysis, how you suspect and treat clinically and with the limited investigation? This is a common problem we are facing.
So we need the help of a good hematopathologist. I'll give you an example. You have a patient whose hemoglobin is low and it's not iron deficiency. It's a microcytic hypochromic anemia. It's not iron deficiency. It's not beta thalassemia. Your HPLC, HbF is not high. If you have a good hematopathologist, he can look at the HB BART, the retention time which is there before, and that the BART peak, alpha peak, they can pick. And somehow, if they are not able to do that also, there is a simple test to look at the golf body inclusion. It's a very easy test, not expensive. A hematopathologist knows how to do that. They can look on the golf body inclusion bodies, which is a classical thing in alpha thalassemia, and you may not have to go for the costly investigation to look for the alpha thalassemia mutation. So a hematopathologist can see the early peak of that BART hemoglobin. If he's not able to do that, then you can look for the golf body inclusion.
Now, one question here. Before marriage, they do tests to detect this thalassemia. No, I was reading somewhere, no, two thalassemia are in love with each other. They want to marry and they're not listening to anybody. What you will advise as a pediatric hematologist or hematologist? They want to marry, both of them, they are minor. What is your advice?
So, Dr. Sharab, we cannot, I would say, let two lovers not marry each other. If they love each other, they have to get married. So they need to understand the fact that if two thalassemia minors are getting married, then there is always a 25% risk of having a thalassemia major baby. So what best can be done? Between 10 to 12 weeks of pregnancy, they should go for CVS. Chorionic villus sampling can be done between 10 to 12 weeks of pregnancy. And if the fetus has got beta thalassemia major, because there's a 25% risk, 75% chance that it would not be a major. If the fetus has got thalassemia major, then if your law, if your religion allows, then you can go ahead and terminate the pregnancy.
Yeah. I would like Dr. Sora, one more comment. Sorry, Doctor, because regarding the low MCV, low MCH, and hemoglobin maybe normal or low, and electrophoresis normal. Yes, one of the most important differential is the alpha thalassemia, and Dr. Vikas very kindly just explained how to diagnose the alpha thalassemia. But don't forget that we have a very rare cases of normal hemoglobin electrophoresis, low MCV, low MCH, but the patient is a carrier of beta thalassemia, not alpha thalassemia. These cases, these cases called semi-silent beta thalassemia minor. Even we have some very rare cases of the silent carrier. So for the cases of the semi-silent beta thalassemia minor, completely the picture of the CBC like this is like alpha thalassemia minor. So sometimes for getting the marriage, we need to go for the alpha and beta gene sequencing. Yeah.
That's a very important point which Dr. Karimi has brought. So let me try to explain it in another way. If you have one of the spouse who has got minor, let's say
Yes.
mother is minor, and you're checking the father, and father has got normal HPLC, means the HbA2 is not more than 3.5, and it is less. It's between 2.5 and 3.5. If it is between 2.5 and 3.5, sometimes you can have a silent carrier.
Yes.
So
Yes.
in those patients, in those conditions, you need to look at the mutation. You need to look at the mutation of the father, because he might also be a carrier. And if you don't do that, you may come up with a surprise, and you may be having a baby who's got a major. So very well.
I have actually some cases, and for the family, the partner, one of the partners is typical of beta thalassemia minor. The other one is just low MCV, low and normal electrophoresis. And they say, okay, it's alpha thalassemia, so go for the marriage, and then the baby is thalassemia intermediate, unfortunately. So it's very important.
Absolutely.
So, Dr. Dua, going on, we finished the iron deficiency and hemoglobinopathy. Now, what's your approach to treating an infection-triggered HLH that does not respond to treatment of the underlying infection?
Yes, that's another very important point, because all of you who are dealing with sick patients or who are in pediatric intensive care units, you may be encountering situations like this, that a septic patient, a meningitis patient, or a pneumonitis septicemia patient coming to you and has got pancytopenia, high ferritin, high triglyceride, low fibrinogen, and deranged liver enzymes. You feel that it's a sepsis triggered HLH, and you start these patients on antibiotics, cultures are positive, and you are giving sensitive antibiotics, still the patient is not improving. That means it is that though you are able to treat the trigger, but as there is a hyperinflammation going on, you need to calm down the storm. You need to calm down the storm with medicines like steroids. Sometimes you don't need the full-blown HLH protocol like steroids, cyclosporin, etoposide, the first-line medicine. Sometimes simple dexamethasone can help. But please understand the fact that please handle these patients with care. Don't just blindly start steroids. Take the help of a hematologist who can help you in bringing out from a tough situation in these cases.
So when do you refer a patient with a newly diagnosed severe aplastic anemia for transplant?
I think all severe or very severe aplastic anemia patients, my take is that they should go for a transplant. Always, it is good to do a transplant who has got a full match donor, a sibling who is a full match with the patient. And if that is not the case, we search the donor from outside the family. That's called unrelated donor transplant. And nowadays we are doing half match transplant for patients who don't have a full match donor either inside the family or outside the family, by taking father or mother as a donor, because 50% of the genes comes from father and 50% genes come from mother. So transplant is always advisable. But if that is not the case, then you can go ahead and give immunosuppressive therapy in the form of ATG cyclosporin plus minus eltrombopag.
This I'm interrupting here. Today you clearly, you cleared this doubt that people think, many people think stem cell transfusion means you open bone marrow and do some surgery there. And the way you said, this is just like a blood transfusion. I think this message will initiate many people to come for this, because this is in the mind of people, even medical profession, that stem cell transfusion means you do something surgical. And as simple you explain, I think now many people are clear about that. Yes.
I think the pediatricians who are listening to us, they need to understand that we are not going to break the bones of the donor. No breaking of the bones. Very simple way. We are just going to collect the stem cells from the blood.
Yes.
Okay. Would you give a trial of IST first or immediately refer to for SCT if the patient has a matched sibling?
So I just said that I've been a transplant physician, and the correct thing also is a transplant rather than going for IST immunosuppressive therapy.
Okay, for T-cell ALL treated in CR without transplant, how often do you do a bone marrow biopsies as part of the surveillance, and for how long?
So this is a bit more technical question for pediatric hematologists rather than for general pediatric people. But I can just tell you that once you treat any ALL or AML patient, you have to do a bone marrow test at certain time points, after 1 month, after 2 months, and after 2 years of completion of therapy. After that, there is no role of surveillance bone marrow. You just follow these patients with simple blood tests like CBC.
Dr. but I would like to change the one question that. No,
Go ahead.
Dr. Vikas and Dr. Karim, how do you advise iron therapy for children? Once I attended a professor from England, he showed us a slide that the UK government Ministry of Health recommends iron supplementation up to 2 years for all children. I am following that advice. Keeping in mind the iron deficiency anemia we are having in the children is so common, I follow this. I tell the parents, give iron normal supplementation up to 2 years. What is your advice?
In India also, Indian Academy of Pediatrics also say the same thing. You need to continue these patients on iron supplement, because this will prevent iron deficiency anemia from happening, because it is not just the hemoglobin which is linked to iron. There are a lot of things like mental development, immune system, which is linked with iron deficiency. So you need to continue these patients on iron supplement, which is going to help. The dosage schedule is different for a preterm and a term baby. The duration is different, but yes, rightly said by you, iron is important for a growing child. What is your comment on this, Dr. Karimi?
Yeah, because a very, very small amount of iron is used in the brain, and it's called monoamine oxidase for transmission of between the neuron cells. So when the iron is low, the IQ and intelligence completely coming down. And if we treat the iron anemia during the infancy, these side effects can reverse. Otherwise, unfortunately, after infancy, during the childhood, treating the iron anemia, maybe the decreased IQ, it should be irreversible. So very, very important. If the patient is on breastfeed from age of 6 months to 2 years, the prophylaxis iron supplement should be given, because the most common age of the iron anemia is 9 months to 2 years. But for those babies who are on the formula is iron 45. So maybe it doesn't need, but for the breastfeed, definitely we should be very careful to give iron supplement.
And this Dr. Karimi said iron and cognition. Many children at the school, teachers say, I mean, parents, they come and say, teacher is saying your child doesn't understand mathematics and analytical work. These are all due to iron deficiency. Iron
Yes, it's
and
very
And
cognition.
vitamin D.
For
And
the brain
vitamin D.
development, for the brain development in infancy, the iron is very, very important
Yes, please.
element. Yeah.
Dr. Diari,
So-
please.
Dr. Dua, do you routinely send the NGS testing for bone marrow samples in patients with unexplained cytopenia or cytosis?
Absolutely. So I think this is very important. Somebody who has got aplastic anemia, you need to differentiate between idiopathic and inherited bone marrow failure syndrome, because there are 30% of patients who have got inherited bone marrow failure syndrome and don't have physical deformity. So each and every patient who has got aplastic anemia, unexplained cytopenias, NGS is to be sent before you plan a definite therapy.
Okay, Dr. Najwa is asking, now we face a lot of viral infections with bone marrow depression. What's the critical level of neutropenia and what's the management?
See, if you have a patient who's got a viral infection, has come to you with pancytopenia, if your ANC, absolute neutrophilic count, is less than 500, then you need to be worried of. If it's more than 500, that means it's a moderate to a mild neutropenia. It may recover. If it's less than 500, your hemoglobin is low, your platelets are low, do a marrow with an aspiration biopsy. If the biopsy shows a cellularity of less than 25%, then you need to be worried. If it is more than 25%, you can wait and watch, and many patients will recover on their own.
Dr. Rahman is asking, how is successful of stem cell transplantation on age-related basis?
Oh, it all depends. Dr. Rahman, we need to understand that for different conditions, the indications are different. The age time point is different. I give an example. You have a patient of hemoglobinopathy, a thalassemia patient, sickle cell anemia patient. Do a transplant early in their life, because thalassemics, the more and more transfusion they get, more and more are the chances of complications like veno-occlusive disease or the liver, or rejections because you get multiple transfusions if it's late. So sooner the better for hemoglobinopathy. Similarly, aplastic anemia, sooner you diagnose, refer these patients for a transplant to a correct center. Sickle cell anemia, I've already discussed. Somebody who has got immunodeficiency, do a transplant on urgent basis, because they may die. They can die. Similarly, for malignancies, those who warrant transplant, early indications. So it's important for us to understand that for majority of conditions, early transplant is the dictum.
Dr. Amir is asking, in workup of immune deficiency, mostly we get the report that absolute CD3 cells are decreased. CD4 and CD8 cells are decreased, but ratio of CD4 to CD8 is normal. Immunoglobulins are normal. How do you interpret this?
So I just said that there are 300 different types of PIDs. So different PIDs. If you have a severe combined immunodeficiency, your T cells, B cells, NK cells all can be low, or you can have different permutation and combination. So you just don't have to go with just CD4, CD8. If you are suspecting somebody to be having immunodeficiency, the easier tests are, yes, definitely immunoglobulin profile and the lymphocyte subset, but you have to look at you need to do the next generation sequencing, NGS, to look at what type of the PID the patient is suffering from.
Okay, another doctor asking a patient 5 years old known to have 1 Willebrand and factor VIII deficiency, taking cyclocapron on need, presented to emergency with oral mucosal bleeding, not responding to oral cyclocapron. So what medication prefer to give to this child?
So it cannot be factor VIII and von Willebrand disease together. So probably it's a von Willebrand disease which the patient has. So if the patient is not responding to the local measures, then we need to understand if your country has got von Willebrand concentrates. I don't think UAE has got von Willebrand concentrates, because in India we don't have. If you don't have von Willebrand concentrates, then cryoprecipitate has got a good von Willebrand factor in that. So you can give cryoprecipitate to these patients, And in case you don't have the facility of cryoprecipitate in a blood bank, then at least FFP, fresh frozen plasma, to be given to these patients, and that will help.
In Dubai, the Wolverine factor construct is available, Dr.
Oh,
Vikas.
great. We don't have that in our country.
Yeah,
so
in case of we don't have, as you mentioned, we have to use the cryo, but here is available.
Great. Then if you have available, please give 1 gram factor
Give 1 gram.
concentrate.
Yeah,
Don't use cryo. Don't use cryo. Okay.
Dr. Tariq is asking, vitamin B12 deficiency anemia is known for megaloblastic anemia. Can it be responsible for the normocytic anemia?
No. So if you have a B12 deficiency, your MCV is going to be high. So it's a macrocytic anemia.
Yeah.
So,
For the macrocytic anemia, as Dr. Vikas said, along with we should consider the folate deficiency, B12 deficiency, but don't forget that sometimes the myeloblastic leukemia, AML, may be presented with macrocytic anemia. And I had several cases coming with the macrocytic anemia and then no response after a few weeks. Wow, the bone marrow showing myeloblast. So it's very careful to close monitor. Yes.
That's absolutely right. So Dr. Karimi is absolutely right in his points, because if you have a high MCV in a patient, just don't blindly go with the indices. Look at the peripheral smear. If you see on peripheral smear hypersegmented neutrophils, macroovulocytes, and confirm that by doing B12 folic acid levels. And once that is confirmed, treat. In case your B12 levels are normal, folic acid levels normal, on the peripheral smear, you're not seeing evidence of like hypersegmented neutrophils or macroovulocytes, then you need to think of something else. It might be a malignancy, what he's rightly saying. It might be something else. So please
Yes.
look at the complete picture rather than just looking at the.
Yes.
Yeah, I would like to take this platform, Doctor, because still we see many reports that are coming, CBC, no peripheral smear. I would like, in this platform, you mentioned a CBC without peripheral smear has no meaning. Still we see patients are coming after CBC, just no peripheral smear. So the importance of peripheral smear, please.
A hematologist talks to a pathologist more often as compared to he talks to his wife. So we talk to our hematopathologist more often because we have to make friends with them so that they can look at the peripheral smear and help us in making the diagnosis. So without peripheral smear, we are very much clueless.
Very important.
Thank you.
Seems people, they like the discussion every time, new question. Okay, so.
No, it is 11.
Yeah.
It is.
It is 11 because I have to go.
It is, 1:13, and in India, it is, I think, 1 hour 12:30.
It's 12:30, yeah.
12:30 a.m.
Yeah.
Every morning. I think few more questions. I'm sure. See,
Till 11. Okay, another 3 minutes.
We are having 500 viewers are following us. Total number would be around 800.
Another 3 minutes, Dr. Zorab. Another 3 minutes till 11.
Please.
How low can the hemoglobin goes down in nutritional iron deficiency anemia?
Oh, we have seen hemoglobin going to 1.5, less than 2. I have seen badly, poorly managed patients coming from low socioeconomic status from villages. We have seen coming them in congestive heart failure with a very low hemoglobin and a diagnosis iron deficiency. So just don't go by the hemoglobin levels. It can be very low. It all depends how vigilant you are, what is your educational level, how you are taking those patients in your nearby. Please try to refer the patients early once you feel that the patient is failed. Don't make them to go to a level which is critically low and is causing CHF.
Okay, so what's your opinion about using desmopressin IV in mucosal bleeding in children with von Willebrand?
So we have not used very often. In mild cases of von Willebrand, you can use desmopressin. That will increase the von Willebrand body and can help in controlling the bleeding. I have personally not used it very often.
Yeah, desmopressin. Sorry, doctor, because desmopressin just using for type 1 and maybe sometimes in type 2. But don't forget that we need to do the DDLP challenge test. DDLP challenge is very important to see that the patient is responsive to DDLP or not. And it's very simple that the patient comes to our clinic and given 0.3 microgram per kg desmopressin IV infusion over 30 minutes, and in time 0 before giving the desmopressin, and 2 or 4 hours, 30 minutes, 2 hours, and 4 hours post infusion, check the DDLP factor activity, antigen, and factor VIII, and it should be at least double. It means that response, very good response, the responder to the DDLP. So we can use in such a cases, in for example, the Wurm-Brand disease type 1 coming with bleeding, we can use desmopressin. Also, there is the some puff instead of the IV, intranasal puff. Very simple. That can be used at home, but it's not available in Dubai, unfortunately. Maybe in some other countries it's available.
Dr. Vikas, last 2 questions. If patient has both iron deficiency anemia and vitamin B12 deficiency, can MCV be normal?
Yes, it can be normal. In dimorphic anemias, it can be normal.
Yes.
Thank you. So the last question will be from Dr. Anwar Sajjad. If child CBC is normal, hemoglobin and other indices are normal, but ferritin is low, what should be action, and what level ferritin iron should be started?
I think that if your ferritins are low, that means your storage or the stores of irons are low. That means you need to start these patients on iron supplement. Don't make that patient come to a point when your hemoglobin and other things also drop. So if your ferritin is low, treat them.
Yes, definitely. We have two different scenarios. Iron is anemia, iron deficiency state. It means that we cannot see anemia, but the storage, as Dr. said, is low. Yes.
Thank you very much, Dr. Vikas, Dr. Karimi, for nice presentation and excellent explanations. Thank you very much.
Now, I'd like to thank Dr. Vikas for excellent presentation, discussion. I would like to give this promise to our viewers that we will have another session. Lot of questions are there. If we go like this thing, we'll go till morning. I would like to thank Dr. Karimi also for joining us. Dr. Diari, Dr. Kalpana is traveling. She was with us on the air. We are so popular now. We are on the air also. Following GPC. I would like to thank Dr. Tawfiq for sponsoring. I would like to thank all viewers. Still, we are having 500 viewers, 12:30 from midnight in India. Thank you very much. I would like to thank all of you. And inshallah, we'll have another session. Thank you very much for joining us.
Thank you all.
Thank you very much, Dr. Shorab, Dr. Diari, Dr. Kalpana, for giving us this opportunity. And thank you, Dr. Karimi, because honestly, I have also learned quite a new things from you. And
thanks to you. Thanks to excellent presentation. Thanks.
It's always good to learn. Thank you very much, and thank you. God bless.
Thank you, and good night. Good night.
Good night. Bye-bye. Bye. Good night.